And we don't know if her primary neuromotor deficit that shows up after a couple of reps is because the nerve is getting irritated or the local tissue is getting irritated. And in reality, it doesn't matter because we're going to take care and protect both. But it is going to be, critical. I'll bet you she'll have findings around her rotator cuff and things that we could treat. But if we didn't appreciate the sensitivity of her nervous system, then I think that it would be very easy to overtreat her, give her exercises that would be inappropriate. It's just so critical. So if you check this out. So I get on here, and can you see the look on her face? Right? Get on here. Oh my God, right. And you can feel the tone in the muscles and the guarding that's going to happen. And she says just like a shock going down her arm. And I can't remember if we did traction in this position, if it was good or bad.
Mm-mm.
It was.
It's not good.
It's not
it's
good.
not good.
It's not good, okay?
No, like burning.
In local?
No,
all the way down, okay? And then if we slacken it, what about that?
Yeah.
Better already, right? And I think she's getting more sensitive as the day goes on, so we got to be mindful about. But when we did it before, this was less tender, but the muscle guarding is pretty great now, huh?
Yeah.
Yeah, so it's just irritated in general. But then her pec minor was on fire. We know that her scalenes are tight. It was interesting that palpating her brachial nerves, where is that guy? Here he is. Not so bad. But if I played with the fascia above it, she said it felt like a needle.
Yeah.
Right. And the stechos talk about that. When you pull on the fascia, it can be pain, it can be burning, it can be feel like a needle when the connective tissue is getting pulled, right? So it's interesting how it's not tender to compression, but if you deal with the fascia above it, it's going to give her trouble, okay? And then as we look down, yeah, right? So with Lori, if we could slacken the nerve, sorry, are you really in trouble? That's fine. It's fine.
No.
Where's the whiskey?
No.
Right. But if we could slacken the nerve and we could address the soft tissue along the chain, if we could get her, make sure that her ergonomics weren't such that the nerve is getting stretched during her day, if we could probably get her doing some rhythmic stabilization in that safe range. Ouch. Yeah, you're really in trouble, huh? Yeah. Sorry. Okay. So, yeah, I think that she's a perfect example of, we looked and said, oh, it looks like a glenohumeral problem. But it's, yeah, sorry. Because of the pain or because of the emotional? Yeah, right. I hear you.
That's why we're here. You can use some help.
Yeah. Okay, so, yeah. All right, so we're going to switch gears. Michael? Yeah. Okay, now we're going to take a look at glenohumeral glides. We're going to start looking at ACSC glenohumeral joint, but it's pretty obvious you got to have some sense of the nervous system before you do.
Okay, could you sit here, please? And take that down. So if we talk a little bit about the shoulder and the glides that we're going to look at. First of all, SC. So the SC most commonly will not be too much of a problem, but it can be when a person has a fall to their side, and it can become hypermobile and displaced. In more cases than not, if a person falls and has trauma to the shoulder girdle, the clavicle will fracture, except during adolescence when the joint is less stable and the SC could dislocate or sublux. Anteriorly would be the safest. The real danger is if it goes posterior, it could hit the aorta, and that could be disaster. So I remember, these are few, but if you remember special career moments, I was involved in an intramural wrestling tournament at San Francisco State and had this young guy who is a non-wrestler, and he had polio on one side. And then he was thrown to the mat by someone who had some wrestling experience. The non-wrestler didn't know how to land very well, and he landed right on his shoulder, and it did sublux interiorly. But fortunately, the aorta wasn't compromised, and this thing was very loose afterwards, so that when he would protract and retract, and you would feel a comparative experience, left versus right, you could feel the looseness of one versus the other. So if you're dealing with young people, then you have to always look at the SC and compare the movements not only with protraction, retraction. Go ahead and do that. Yep. And then now it's behaving like a concave joint, so that the surface that I'm feeling anteriorly should come to my fingers as she protracts, and then it should move away from my fingers and the sternum as she retracts. It's a saddle joint, so that when she elevates, then the surface that I'm palpating should glide inferiorly as the bone rises superiorly. So it's a convex joint in the elevation depression, and they should also be symmetrical. Okay? So you're then going to be able to hold, so scoot closer to me. If I had this side and I pulled the bone and then I tractioned it, I should feel that there is a difference when a person has pathology, either in that the pathology was old and it's stiff, or it's rather fresh and it's hyper and maybe need to be immobilized. Okay? If we look at AC, yeah, if you wouldn't mind. So AC injuries oftentimes will occur with a fall on the shoulder directly, either laterally like this or anteriorly. So what will happen is visibly you will see that one side is higher than another. If it is a pain generator, there are about 3 tests that would indicate a summation to make you conclude that the AC is the pain generator. So I would compare the pain-free side into horizontal adduction and then go passively with overpressure and then compare that to the involved side, and then if it was positive, that's going to make you suspect AC. They will also have a difference in elevation in that the painful AC will not allow full elevation compared to the opposite side. And then there will be a difference in what is called joint compression. And the joint compression test is first done on the uninvolved side. And I have my hand underneath the scapula. And then I take my other hand and not compress a strap, but I'm going to compress the joint by stabilizing the inferior angle of the scapula and then compressing the clavicle into it. I'm going to show you on the model. so that my hand would be on the inferior angle here, the clavicle's attaching right here, and then I'm going to push the clavicle into the scapula in this manner. Okay? So if the compression is done initially on the pain-free side, and then I come over to the involved side and it's painful, that's a second test or a third test to go along with the overpressure on horizontal adduction and the elevation difference. Okay, then we look at the joint glide, just like we did for SC. So we would stand on the non-involved side and I feel core cord right here. So I know I have the scapula stabilized anteriorly. Then my thumb goes along the spine of the scapula. So I have coracoid and spine of the scapula. And then I'm going to move the clavicle anterior-posterior. And then I move it this way, anterior-posterior, and then I would then come to this side and do the same thing. And this one's a little looser. Okay, then the final thing I would look at are the ligaments, and I'd palpate them for thickness. Anteriorly, simultaneously, so she can have a comparative experience, and I'd then feel posteriorly. So what I'm doing with this is getting my own feedback of how the anterior ligaments feel, left versus right, and posteriorly, left versus right. But she's also understanding how there's a difference in tenderness. Oftentimes, if you have young people, because they have a lot of falls, and they've done this joint, I'll have the parent come and feel the difference of one side moving in comparison to the side that's been injured. This is especially important when the parent needs to realize they need to be held back, and you need the buy-in of the parent, not to be overridden by some zealous coach. Okay? Also, I can then have, if it's a young 20-year-old, they can put their own finger up here, and then you can let them see how much more motion there is on the involved side versus the other side, to let them know that this needs to be treated. So oftentimes the treatment could be ice cup going around the groove of this, cross fiber massage, and then not irritating it with the painful directions that we already talked about. Okay, so that looks at SC, AC. Okay, then we have to look at the glides of glenohumeral.